Good evening, folks. This is Dr. Paul. Thank you very much. Today, I want to talk a few minutes about keloids. Keloids, and they should not be confused with hypertrophic scars. They both represent dermal injury characterized by local fibroblast proliferation and overproduction of collagen. So keloids, for example, they are like fibrous growths. So these fibrous growths, they extend beyond the original area of injury to involve the adjacent normal skin. So they go beyond the wound area. So they involve even the adjacent normal skin. Hypertrophic scars, they look like keloids, but in contrast to keloids, they remain confined within the boundaries of the wound area. And the other difference is they regress spontaneously over the time. So that's very important. Keloids, they only become worse and worse with time, whereas hypertrophic scars, they heal with time. Both cause functional impairment and cosmetic disfigurement. So you need to remember to improve the quality of life of the patient. Keloids affect men and women equally, and they are more common in younger individuals. There is a family tendency to develop keloids. For example, you see that in parents and then also in children. Because there is some genetic component to this, autosomal dominant inheritance with incomplete penetrance. Let us see pathogenesis. In normal wound healing, what happens is there is an initial marked local inflammatory reaction, and it is followed by formation of new blood vessels, activation of keratinocytes, fibroblasts at the edge of the wound, and there is this synthesis of extracellular matrix components. After the re-epithelialization is completed, the dermal granulation tissue is remodeled into a scar, and the replacement tissue adapts to biochemical requirements. Fibroblast proliferation and collagen synthesis, they are greatly increased in hypertrophic scars and keloids. There is this overexpression of growth factors such as transforming factor beta and vascular endothelial growth factor and connective tissue growth factor. So these growth factors, they improve, they overreact, and they make these fibroblasts to proliferate and synthesize more collagen, and they promote the differentiation of fibroblasts and myofibroblasts. So myofibroblasts, they contract these actin filaments, and there is a high production of collagen, and there is this contraction that increases the disfigurement with the time. So in normal wound healing, transforming growth factor beta activity, it diminishes upon the completion of wound repair. But in keloids, TGF beta is overproduced and it is poorly regulated. So that is pathogenesis. As I said before, there is this genetic component in Asians and Africans. They are more susceptible to the development of keloids. And when you come to clinical features, the hypertrophic scars, they usually form at sites of surgical wounds like lacerations, burns, inflammatory, infectious skin conditions. Take people with acne, folliculitis, chickenpox, people with who got vaccinations. They develop these raised erythematous lesions. And if there is a wound, you see that hypertrophic scar. Keloids, they present as raised dermal lesions, and as I said before, they extend beyond the boundaries of original wound and they invade the surrounding healthy tissue. And predominantly upper chest, shoulders, upper back, head and neck, these are the areas to get these keloids most commonly. And as early as 1 month after trauma, they start to get worse and worse. In contrast, hypertrophic scars, keloids, they do not regress with time. They only get worse with time. People complain of pain and pruritus and also the irritability. And sometimes they invade the nervous tissue and cause neuropathic pain. And diagnosis. How do you diagnose these patients? Many times it's just clinical. Take history, see the lesion, and you will see it's a keloid. If you have doubts, do a biopsy, and it will definitely show you what's going on. Then let us talk a few minutes about the treatment options. Basically, you see, take what is this? How is, ask a few questions. How is this affecting you? What kind of problems you have? What is this color? What is it? Take some photographs, because that helps you to monitor the progress. There is also a Vancouver scar scale. Basically, they take this pigmentation, vascularity, pliability, height. So that scale tells you the severity of these lesions. So take the scale, take some photographs, take a good history. And also goals. What are you looking for? What is bothering you more? Are you worried about the appearance, or are you worried about the pain and other symptoms you're having due to this problem? So the goals of therapy, write down the goals of therapy, then provide the treatment options. I usually use intralesional corticosteroids. Corticosteroids, you take something like a triamcinolone, so add a little bit of lidocaine and slowly go into the lesion and inject that steroid. It reduces the symptoms, and many times people feel better with intralesional corticosteroids. That is something that we could easily do in an office. So just to prepare the area, clean it up with like betadine and take some lidocaine and fill it with a little bit of triamcinolone and then inject it. That's first. Second, there is also intralesional 5-fluorouracil. 5-fluorouracil. Basically, what it does is it induces apoptosis and it inhibits the transforming growth factor beta. So 5-fluorouracil, it is basically increasing the depth of the tissue. So it's not like steroids. Steroids are actually promoting that they are inhibiting the growth of fibroblasts, but these are actually causing the death of fibroblasts by increasing the apoptosis and necrosis of fibroblasts. So 5-fluorouracil, but I mean, getting that from a medical supply is not that easy. Then silicone gel sheets. These silicone gel sheets are silicone gels. When you apply, they increases the hydration of stratum corneum and they generate static electricity. And because of that, fibroblasts start to regress in size. So silicone gel sheeting is another method you can use. Or silicone gels are another treatment method that helps these patients. Then there is pressure therapy. There are some special devices. What they do is like these special garments and bandages. They basically, you apply them to the keloids and they apply pressure and they flatten them with the time. This pressure, what happens is it reduces the oxygen tension and it occludes the blood vessels and it stops the proliferation of fibroblasts and myofibroblasts. And this diminution of peripheral blood circulation eventually causes the reduction of fibroblasts and also the size of the keloid tissue. So pressure therapy is another thing you can think about. Then there is cryotherapy, where you take liquid nitrogen. I mean, the same cryotherapy you use for warts, for example. You can take that and for 10 to 30 seconds you repeatedly go into this lesion and apply this. So intralesional cryotherapy, what it does is it destructs that scar tissue. It forms a blister around, and the blister basically it destroys the scar tissue. But unfortunately, you have to do this again and again to see improvement in these lesions. So cryotherapy is something you can think about. Then there is excision. You give lidocaine, take a blade and excise the whole thing. But the problem is 100% of the times the keloids will come back. That's the bad about this thing. So you always tell the patient, well, we can cut them off, but unfortunately they will come back. So you see, cryotherapy, and if cryotherapy, some people may say, I want just excision. So just excise it after taking the consent from the patient. Then there are other agents like imiquimod. Then there is radiotherapy. Some patients take this external radiation beam and apply this. and this radiotherapy is highly effective in reducing keloid structures. So radiation therapy is one aspect also, but it's not available in a normal office. So in a normal office, what you can do is intralesional corticosteroids, intralesional 5-fluorouracil. You can do cryotherapy. You can do silicone gels, pressure bandages. You can also do excision. So these are the different treatment options we have for keloids. But unfortunately, these are not cures. They can only help to some extent. And we haven't found a medication that will completely takes away a keloid, not to come back forever. Unfortunately, that's not available at this time. But most of these treatments in combination, they improve the quality of life of these patients. I hope this helps. Thank you very much.